I guess I'll give like a little bit of an introduction. Hello everyone. Thank you for joining this week's seminar. It's going to be a guest speaker event with Jennifer Simmons, who is a consultant neurophysiological scientist, and she works to diagnose patients with a range of neurological diseases. So this is going to be a very nice introductory type of session to clinical neurophysiology. And we will have another guest speaker later in the year who will be talking more about like a more detailed um, presentation on the types of tests, so such as EEG and EMG, that happen in clinical neurophysiology. So it's like a really nice way to learn about these skills. We'll get started in about 4 minutes, just to let everyone in. And yeah, if you have any questions, please make sure to drop them in the chat so then she can answer them. Thank you very much. Jennifer, I guess you can just start now.
Lovely, thanks, Serena. Okay, hi everybody.
Sorry,
Serena,
you might want to turn on your on your camera.
thank you. As Serena said, I'm Jennifer Simmons. I work in clinical neurophysiology at Nottingham University Hospitals. And I'm just going to give you a nice introduction to clinical neurophysiology and talk about the main tests that we see. And sorry, I've just got to get you to go through what we're going to look at today. So neurophysiology is a branch of healthcare science. So I'll talk to you about what that is, and I'll briefly describe other careers in the area. And then we'll hone down and look at clinical neurophysiology itself, the tests, conditions, diseases, and then also the different working environments that we get to go to. Can everybody hear me okay before I carry on?
Yes, but I think your camera is turned off again.
Okay, is that better?
Yeah.
Yeah. I think every time, Every time I move the slide along, the camera goes off. I'll try and remember to turn it on.
All right.
So, healthcare science, I've given everybody a link there if they wanted to jot it down to have a look at this after we've finished this little talk tonight. It's a branch of science to do with diagnostics and equipment in the health service. There's lots and lots of different professions. So the first of these are life sciences. These tend to be laboratory based, and I would say the best known of these would be biomedical scientists. I'm sure that you've all heard of those, but there's many, many more. There's also an area within healthcare science called clinical bioinformatics. And from what I've read, I don't know anything about this area of work, but they are concerned with the organisation and storage of biological data. So, for example, in genomics and things like that. Then there's the physical sciences and biomedical engineering, which I do know a little bit more about, and we work fairly closely with these members of staff. So this is to do with radiography, ultrasound, but also the people that check how equipment is working, and also start developing new equipment. And then there's where clinical neurophysiology sits, which is in the physiological sciences. This is a huge group. I've given you a few examples across the bottom there. It includes audiology, so to do with hearing services, the cardiac sciences, so people that diagnose cardiac disorders with echocardiography, exercise testing, and then also pacemaker fitting. Vascular science, which is a growing area, ultrasound on vessels, veins, arteries, and ourselves, neurophysiology. A slide to move forwards. Okay, and then how do you get into neurophysiology or any of the physiological sciences? So you can start without a degree. You can become a healthcare science assistant, and these sort of posts are advertised on NHS jobs, and you can just apply for those, and if you're very lucky, those posts can often lead to apprenticeships, etc. So they're worth looking out for if going straight to university isn't for you. Then you can also come in and do undergraduate degrees at universities, and once you exit from those degrees, you are usually qualified at a basic level to do the tests and get a job within a department and progress from there. During that degree, you're usually given placements, probably 6 to 12-week blocks within a department where you learn the clinical skills that you'll need to qualify. There are also degree apprenticeships, so these are advertised through NHS jobs, and you can apply. You will be hosted within a department, usually for the duration of the degree, so for 3 years. You will earn a salary, a full-time salary, and your degree would be paid for, and you would do your degree on block release. These are great opportunities. Keep your eyes out for these. They are few and far between. Competition is high, but if you get one, they are brilliant. We've had one member of staff at least in our department. After that, once you are qualified at the basic level with the BSc, you can progress and you can do the MSc on the scientist training programme. If you've done a degree of BSc, if you've done a BSc that is within any science subject, particularly biology, we've also had people from sports and exercise medicine. If you want to come into neurophysiology or any of the physiological sciences, after that BSc, you can apply to the scientist training programme as well. That works similar to the apprenticeship, although it runs separately, Recruitment is once a year. We could talk about this more at the end. The application process is quite rigorous, but definitely a great role. You would be employed, again, a full-time salary, and your MSc will be paid for. Following on from that, usually once you're employed in a department, there is the higher specialist scientific training. This is a doctoral level award, and it's something that you would only usually do once you've spent a few years at least, probably several years, working within your area of physiological science. Okay, so now to clinical neurophysiology itself. This is our department sign within Nottingham University Hospitals. I've provided you another link there to our professional association. You can go on there and there's links to careers information. So what is clinical neurophysiology? So it is investigating the function of the nervous system to diagnose and manage a range of neurological and non-neurological disorders. Can you still hear me, Serena?
Yes.
Good. We see adults and children, a huge diverse patient range, and we do 4 main tests: EEG, nerve conduction studies, electromyography, and evoked potentials. And that's what I'll go through with you today. I also didn't want to leave out that we have doctors in clinical neurophysiology. So I know many of you are looking to go to medical school. And if this is a profession that interests you, it's not only becoming a scientist, you can become a doctor, a consultant within clinical neurophysiology. The consultants provide more complex tests. They report and provide their professional opinion on studies like the EEGs and the nerve conduction studies. They often manage services, they do research and audit, and they may develop new techniques as well. It's a nice profession to be in. So to the first test, electroencephalogram, EEG for short. This looks at the function of the cerebral cortex. It has many uses. The main role is in the diagnosis and management of epilepsy though. There are many forms of EEG. So we can do an outpatient EEG where somebody attends for the test. We pop the electrodes on the head, as you can see in the picture there, and we record the EEG for about 20 minutes. We can also do tests that are a little bit longer where we try to get the patient to sleep. And we can also send patients home with a small box that is attached to their body, just in a little bag, and we can record the EEG for 24 hours or more in that way. So, epilepsy. I've provided another link there for people if they wanted to learn about epilepsy. There's 2. The ILAE is more of a professional organisation, but you will find a lot of very good information on that. Epilepsy.org.uk is a charity, and the information there is much more readable, easily accessible. So epilepsy is a condition that affects the brain and it causes repeated seizures. Epilepsy can occur at any age, so from babies to adults through to the elderly person. It can be a lifelong condition or it can occur for a limited amount of time. There are many types of seizures. I don't know if you are aware of these. Some people have impaired consciousness during a seizure. Some people remain aware throughout. And seizures can also be split into whether they affect the whole brain, known as generalized seizures, whether they are focal seizures, or if we don't know which area of the brain they affect. So does anybody have any personal knowledge of epilepsy? Okay, we'll move on. So this is a first case study. I thought I'd present a few case studies for you as a way of learning about the test that we do today. So this is a 6-year-old female. She had normal birth and delivery and normal developmental milestones and was doing very well at school until recently. Her teachers and her parents have both noticed that she's not concentrating and she looks as if she's daydreaming. Mum describes needing to repeat herself when she's talking. Has anybody got a clue what sort of events or what might be going wrong with this young female? Okay, so potentially if somebody stops concentrating at school, it doesn't always have to be something complicated. It could be a hearing loss issue, or perhaps they can't see what's going on. So it could be getting simple things like hearing and vision checked. But sometimes it can be an attention problem or something going wrong where the patient might have impaired consciousness. And if that is suspected by the doctor, then an outpatient EEG would be asked for. So we can do a routine EEG. We would usually get the patient to lie on the bed and lie mainly with their eyes closed, and every now and again we would get them to open them. I've got an example of an EEG here. I will just hold on. Let me just stop sharing that, bear with me. Oh. Sorry, if I come back to here. And I'll just open up another window. Can you see this, Serena?
No.
Okay, bear with.
Yes, I can see that.
Great, okay. So this is an example of an EEG. So you can see there's an awful lot of information there, but these are in effect and very simply termed the brain waves. So we have got lots of electrodes on the head. They are picking up what the brain is naturally doing, and we can look at the frequencies and the amplitudes of these waves. If you can see, if you look at the 4th line and the 8th line and the 12th line, they've got this nice rhythmic activity. It's probably the most prominent activity on the screen, and it's probably between 10 and 12 hertz, and that's called an alpha activity. That occurs when somebody's very relaxed and they're lying with their eyes closed. I should point out that each marker on the screen, so here and here, this is 1 second. So this is how we can measure the frequency. I will just go back to the presentation now. And go. Okay, and also during the EEG, we do activation procedures. So these are procedures designed to bring out abnormalities that we wouldn't see with a patient just lying there with their eyes closed. These include hyperventilation, which I've put the little picture of the girl there blowing out the candles. So we would get patients to blow in and out through their mouth for about 3 minutes. And this actually alters the level of carbon dioxide in the blood, causes some vasoconstriction everywhere in the body, which makes you feel a little bit dizzy, and also alters the brain waves. And this can bring out abnormalities. We can also get the patient to sleep. Certain types of abnormal activity are enhanced during light sleep, and that can be very helpful. We have a surprising number of patients that do fall asleep in the test. And then we can also do photic stimulation, where we show patients a flashing light to make sure that they're not having any seizure events that are triggered by flashing lights. Oh. So here I have got an example. I suspect I'm going to have to share my screen in a different way again. I've got an example of what is going on with our 6-year-old female. So here we go. So I've just shown you that example of a normal EEG, but now you can see an example of what would be going on in our case study of the 6-year-old female. She would be having an absence seizure. And during an absence seizure, a patient becomes temporarily and quite abruptly unaware of their surroundings. They maintain their posture, they may stare, they may blink their eyes a few times, and the brain waves during this time show a very stereotyped pattern of 3 Hz spike and wave activity. So you can see that it looks very, very different to the EEG that we saw before. Has anybody got any questions about that? So a patient that has absence seizures, like our case study lady, she would usually be treated after an EEG showing that type of 3 Hz spike and wave activity with anticonvulsive medication. In this case, it would usually be a medication called ethosuximide. And generally the prognosis is favourable for these patients. Up to 3/4 of patients will grow out of these types of seizures, provided that they don't start having other types of seizures as they get a little bit older. I've got another case study. This is particularly to illustrate to you how all of our work doesn't take place in the outpatient department. We go up to wards frequently. We do inpatient studies. We see gentlemen like this 50-year-old male who is usually well, lives with his family. He has high cholesterol and high blood pressure, but is medicated for those. For the last few weeks, he's had a headache and he went to his GP. In the last few days, he's also felt a bit sick. He has been sick and he's had a high temperature. He's become increasingly sleepy and difficult to rouse. His family are very concerned. They phoned the paramedics. He is also having occasional facial and arm twitching, and he's actually underventilating as well. So the paramedics take him into hospital. Because he's underventilating, he requires admission to the intensive care unit where they can take over his breathing for him with a ventilator. And whilst he is on the intensive care unit, this facial and arm twitching that the family had described is seen again. And the doctors want to know, what is this? Is this just an involuntary movement, or is the patient having seizures? So it will come as no surprise that this patient is having seizures. And I've got another example of a type of seizure that we'll see here. Let's just stop sharing that and just, yeah. Okay, so this is an example of another type of seizure. I hope you can all see that well. We've got some colours on here. So what I can show you here is that all the blue channels are on the right side of the brain. The green channels are on the left. And let's just concentrate on the blue and the green. That'll be much easier for you. Can you see about 1/4 of the way into the screen, the green channels start doing some rather fast activity. And that is like an early seizure activity. It is getting faster, it's building up, it's getting bigger. And as it progresses, so about halfway along the screen, the right hemisphere, so the blue channels, also starts to be involved. And this patient is having a focal seizure that then spreads to involve the whole brain. Okay, so this is the type of patient that we would see on ITU. Once they know that the patient is having seizures, they can treat the patient with anticonvulsant medication. This example that I've given you, is typical of an autoimmune encephalitis. So this is an inflammation of the brain, but not caused by an infection. It's caused by the body in some way attacking the brain itself, making autoantibodies. And it's presented, as I've said, to show you the range of patients that we see, and that we do sometimes go to the intensive care unit, probably at least every day in our department. Okay, so that was a whistle-stop tour of EEG. This is nerve conduction studies and EMG. I've given you a little picture there. So now, instead of looking at the brain, we've moved to the peripheral nervous system. So you can see the blue stimulator that we're holding on the back of the leg provides stimulation of the peripheral nerves with a small electric pulse. That depolarizes the nerves, and we can then record the response from some little stickers that we place over the course of the nerve further along. We can do it in many different ways. So this picture here is showing a sensory nerve. This sensation of this nerve, it picks up sensation to the lateral side of the foot. This is recording nerve activity and the way it's supplying a muscle in the hand. And this muscle lets you spread your little finger out to the side. We record waveforms, as you can see in front of you here. They're much more simple to look at than an EEG. There's a lot less information on the screen. We can look at the time. So in this example here, one of these divisions, so from here to here, is 1 millisecond. And in this axis here, in the vertical axis, one graticule, as we call them, is 20 microvolts. So we can look at the time that it takes for a response to get there, the size, and then also using a little bit of physics, we can work out the velocity. I'm sure you're all aware of distance over time equals speed. And then we combine this with our knowledge of anatomy, and we can work out what is going on with people's nerves when they have certain complaints. There's another case study. This lady is a 45-year-old female. She is a hairdresser, fit and well, no medications normally. She works in administration. For the last few months, she's been waking up at night and her hand feels numb. When she wakes up, she shakes her hand a little bit and the feeling comes back. When she wakes in the morning, her hand is also numb again. She also feels as if her hand is weaker and she's struggling with fine grip. For instance, buttons and zips. She's finding it painful and it's making her very tired. Does anybody have any idea what might be going on with this lady?
Could it be neuropathy?
It could be neuropathy, yes. So definitely people, we all know about patients with diabetes. They can develop neuropathy. People can develop neuropathy for many different reasons. We can also have things called entrapment neuropathies. So nerves can become trapped within the normal structures within our body sometimes. And that's what the example that I've given for this lady. So she's got something called carpal tunnel syndrome. Just going to move this here. So she has got a nerve trapped at her wrist. It's very, very common. I've given you there the incidence of it in the UK. And it actually, this nerve affects the median, this carpal tunnel syndrome affects the median nerve. The median nerve supplies the thumb, the index finger, the middle finger, and half of the fourth finger. And very astute patients, if you ask them which fingers are going numb or tingling, they will be able to tell you that it's mainly this index finger, thumb, middle finger. We can then do a nerve conduction study and we can assess these nerve impulses across the wrist. There's a small diagram here, so we put some ring electrodes around the fingers and we record the response at just past the wrist, and we rely on seeing a slow velocity across the wrist here. An example of what we see. In a normal patient, we see figures like this. The important thing here is this 58 meters per second. So the speed of the nerve, this is normal range. But in a patient with carpal tunnel syndrome, the velocity across the wrist will slow to anything. 42 is a good example, but it can be even slower. It can be in the 20s, depending on how severe the carpal tunnel syndrome is. And we do these tests. We don't just do one recording and leave it there. We do these tests according to set protocols, national standards. We always assess other nerves. So just because we think it's the median nerve, that doesn't mean that's the only nerve we look at. We look at the other nerves in case, like Serena said, it is a more generalised neuropathy, and then we can be sure that we've picked that up. So if it is carpal tunnel syndrome, just to give you a little idea what happens to these patients, usually we could perhaps advise them to limit anything that makes the situation worse. Obviously you can't avoid going to sleep, but sometimes prolonged activity on a mouse or holding your hands up will provoke the symptoms. They can also do physiotherapy, so things like nerve gliding exercises, and also we can provide people with wrist splints. So these are small gloves and they have small fixed bars across the wrist. This prevents overflexion of the wrist, which limits the symptoms occurring. If that doesn't work, people move on to potentially have steroid injections at the wrist, but you can only have a few of those and they only work for a limited time. If that doesn't work, surgical decompression is very commonly performed. This is a fairly simple operation, as with any operation, not without risks, but it usually only takes about 20 minutes, probably about a 6-week recovery. How are we doing for time, Serena? We're okay, aren't we?
Good, yeah.
Yeah, good. Okay, so another case study. This is another example of the type of patient that we would see for nerve conduction studies. This is a young male. He's usually fit and well, and he had an episode of diarrhea and vomiting 3 to 4 weeks prior. He made a good recovery from that. He's gone back to work, otherwise fine. But yesterday he developed some tingling in both of his legs. And then 2 to 3 days later, he developed some weakness in his legs, and that's now causing difficulty with walking. He feels off balance and as if he's lost strength in his legs. He goes to hospital and he gets admitted. Whilst he's admitted, he starts to notice that he's also developing tingling in his fingers. Has anybody got any idea what could be going on with this patient?
Something to do with the spine and how maybe the nerves are getting trapped?
Yeah, absolutely. All the signals in the body are travelling through the spine. That's a very good guess, and that would definitely be one of the things they'd want to rule out. So this patient would probably be having an MRI, especially because he's young and fit and well. The example that I've given, though, is of Guillain-Barré syndrome. So this is another autoimmune condition, so it's not something that you catch, but it is commonly triggered by having an infection. In the example I gave you, it was a GI infection, so nausea and vomiting, but it can also be a respiratory infection. This infection causes your body to make antibodies, and then after the illness, those antibodies kind of go rogue and they start attacking parts of the nerves. And in particular, the most common thing that they do is start to attack the myelin sheath. This is just a very simple diagram. I don't know if you are all familiar with saltatory conduction, if you've all heard of this. No, okay. So as you do more biology, this will come up. But as the signal runs along a nerve in this direction, it doesn't just run continuously, it jumps across myelin segments, and this makes the speed of transmission really fast, and it means that it's very effective and it gets signals from A to B within 50 to 60 meters per second, as I've described. But in Guillain-Barré, if the myelin sheath is attacked and the myelin disappears, it may jump across one segment of myelin, but where there's no myelin, the transmission will go very slowly along the nerve, or it will fail to propagate and the action potentials will just die off. So this can have quite devastating effects on patients. This is an example of the sort of figures that we would see. So again, I've given you a normal here, so the top two columns. Don't worry too much about the figures. The difference I've put in red here. So basically, the normal time that it would take to, if we are stimulating at the wrist and recording here, and stimulating at the elbow and recording here, it would take 2.8 milliseconds and 6.8 milliseconds. This is just a rough guide. But in Guillain-Barré syndrome, the patients often, it takes longer to get from here to here or anywhere in the body. And that's because of this failed transmission and the loss of saltatory conduction. And what that means when we calculate the conduction velocity is we get a very slow conduction velocity, 33 meters per second in my example. And this is why the patient is weak. And in some cases, you'll see here that I've made the signal smaller. So when we're looking at amplitude, we're looking at how many fibers are sending that pulse well. And in the normal person, it's the same. All the fibers transmit at the wrist and all the fibers transmit at the elbow. But in a person with Guillain-Barré syndrome, because of this loss of myelin, not all of the fibers will transmit. And so the signal gets smaller, and this is why the patient's weak. So just because I presume that you're all interested in patients and illnesses, just to give you a little idea about GBS, this condition has a very distinct time course. Generally, it takes up to 10 days, possibly 2 weeks, for the peak symptoms to appear. This is called the nadir, and if you were to draw the symptoms on a graph, it would be like this. And then this is followed by a period of recovery, and the recovery and how long that takes will depend upon how severe the symptoms were. It has variable severity, so some people only ever get tingling in their feet or hands and hands. Some people it impacts upon their motor function of walking, like in our case study. In some people this will affect the muscles that supply the breathing, and therefore these patients need to go to ITU to have the ventilation taken over for them before they start to get better. Other tests that are used to diagnose Guillain-Barré syndrome, as well as nerve conduction studies, are lumbar punctures. I hope you've all heard of those. That's where they pop a little tap into the spine and analyse the cerebrospinal fluid. And MRIs, as Serena said, we would definitely want to exclude other causes going on with the spine and also look for any typical changes that might be associated with GBS. And the treatment for Guillain-Barré syndrome is to give people intravenous immunoglobulins, otherwise known as IVIG. They have this over 5 days as an infusion, and this basically modulates these antibodies that are attacking their own myelin sheath. onto EMG, which is often done as an adjunct to nerve conduction studies. So nerve conduction studies and EMG usually take place in the same room and often on the same patient. So these are needles. I've given you an example of the needles here. They're very fine needles. We insert the needle into the muscle. It's attached to a cable that attaches to our machine. We hear noise and we see lots of waves on the screen. We look at the muscle at rest, when we ask the patient to weakly contract, and then also we get the patient to do a full contraction. So it's quite a good workout doing this test. This gives us information about the muscle itself and also the nerve supply to the muscle. This has wide-ranging uses, and together with nerve conduction studies, we look at neuropathy and entrapment neuropathy, as we've said. Also, we can look at myopathies, which are disorders of muscles themselves, causing weakness without any symptoms of tingling or sensory loss. Radiculopathy, which is a term used to describe spinal nerves that are trapped as they're exiting the spinal cord. Usually they're trapped by discs and things in the spine. Patients get a radicular type pain that can also consist of tingling and weakness. There's also plexopathies, so after nerves come out of the spine, either at the neck or at the lower back, all the nerves intermingle before they go to serve our limbs. And where this intermingling goes on, if people have injuries here, then this can cause variable effects on the limb. And so we can detect whether the problem is at the level of the spinal nerve, at the plexus, or within the nerve in the limb itself. We can also look at anterior horn cell diseases, the most common of which you'll probably have heard of, motor neurone disease. And also there is a condition called spinal muscular atrophy, which you may have heard of. And we can also look at neuromuscular junction disorders, so how signals get from nerve across to muscle, and there's quite a few of those as well. Okay, and last but not least, we can do evoked potentials. So evoked potentials work similarly to a nerve conduction study. We give a stimulus and that excites the nerves. The difference with an EP is that we record this response from the central nervous system, so either from the brain or from the spinal cord. So we stimulate a nerve in the limb and then record the response from the spinal cord or brain. We can stimulate the eyes with a checkerboard screen. We can stimulate ears with headphones and a series of clicks, and we can stimulate limbs with an electrical pulse. We can do this for conditions such as retinopathies. It is part of the newborn hearing screening pathway. So all newborn babies have their hearing test, and if they fail the first part of the test, then they will go on to have hearing tests that are based upon the principles of evoked potentials. And then also we can look at conduction through the spinal cord. And this is what we mainly do in our department when we use EPs. I've given you a little example here on the right of the type of waveforms that we see here. The first one here is a response at the shoulder, and then a response just from the back of the neck, and then here responses from the cortex, from electrodes that are attached to the scalp. So evoked potentials can be used in the theatre environment, so the operating theatre, for patients with scoliosis. Has everybody heard of scoliosis? It's a curvature of the spine. So this picture here, this shows a curved spine. This is a condition that happens fairly commonly, especially in young females, but also in males, and it often occurs during adolescence. And they can do surgery where they insert lots of screws and rods to straighten the spine a little bit. And here you can see the impact on this lady's posture of the scoliosis. We stimulate the nerve at the ankle continuously throughout the surgery. The response travels up the leg, through the spinal cord, and we record it either at the back of the neck or from the brain. And what we do all the way through the surgery is we can look and see how big the responses are, and if those responses get smaller, we can tell the surgeon, and that means the spinal cord is under some stress as they are trying to straighten the spinal column. It's very useful. We can also we also do another form of evoked potential called motor evoked potential. That's sending the signal the other way. We can stimulate the cortex and send the signal down and record it from muscles in the body. Okay, so in summary, hopefully I've introduced you to the area of healthcare science and how to get into a career in clinical neurophysiology. And we've summarised the tests that we do: EEG, nerve conduction studies, EMG and evoked potentials. I've introduced you to a few diseases and conditions that we encounter, and also hopefully I've tried to show you the different working environments that we go into. So as well as our own department, we go to wards, intensive care and into the operating theatre. It's a really interesting career, and it would be the same whether you're a scientist or a doctor. It can be quite nice and varied. Okay, so over to you guys if anybody's got any questions.
I'll suggest looking at the chat.
Yeah.
Because most people will write down their questions now.
So we've got a question here. How do you work alongside doctors, nurses and other healthcare professionals? So we work really closely with the other healthcare professionals. We've got lots of multidisciplinary teams. We work particularly closely with neurologists and spinal surgeons, and also the doctors on intensive care, but physiotherapists as well, nurses. We work as a team. We have meetings in the department for paediatric consultants. They come down and view EEGs and we have discussions about them. Yeah, it's definitely a whole multidisciplinary team. When you carry out the EMG and look at the trace, how do you know if it's nerve or muscle problem? That's a really good question. Lots of training is the answer to that. The signals that we see have normal characteristics. The characteristics that we look at are amplitude, morphology, so often how many phases a wave has, and also how broad, so the duration. And by looking at the amplitude, the morphology and the duration, we can tell if the problem is nerve or muscle. What pathway did you personally take to enter clinical neurophysiology? Well, I've been doing the job for a very long time. So I actually started in 1993, so probably before many of you were even born. And I answered an advert in the paper for a job in physiological science. I rotated around all of the physiological sciences, including cardiology, audiology, etc., for about 12 months. And then I specialised in neurophysiology. It was the one that I liked the best. And then once you specialised, they would train you to basic qualification status. Then I got a job at Nottingham. And I've continued to learn. So I've topped up and done my BSc in 2001, I think it was. And I've also done an MSc a lot more recently in 2021. There is always something to learn in neurophysiology. What other types of EEGs in your department? So we do lots of different sorts of EEGs. So EEGs are very varied depending on the patient group, first of all. So whether they are babies through to adults, different techniques are required. Adults will sit and let you attach 25 electrodes to their head. Children, babies will not. After that, we do sleep-deprived EEGs. We do ambulatory EEGs. We can give patients, or we don't give the medication, but the parents do. They can give melatonin to patients, children usually, to try and get them to sleep. And we can also do something called video telemetry, where patients are inpatients on a neurological ward, and the patients stay in usually for 5 days, and we try to capture their seizures. And these tend to be for patients that are having seizures that have proved difficult to control for one reason or another. How is spina bifida diagnosed early, and what are the signs parents should notice? Unfortunately, Dr. Nihal, I may have to defer to somebody else because I know very little about spina bifida, I'm afraid. Serena has asked, what opportunities are there for progression in this field? Opportunities for progression, yeah, they are there for everybody. So if you're working within the field, then it's relatively easy to try and get access to the scientist training program, so the STP program. And once you get that, you'll be qualified to MSc status, which lets you progress. There's a few other routes that you can take. I've done something called the Advanced Clinical Practice degree, MSc. So that was a slightly different route. And then I mentioned the higher specialist scientific training. So we've got a couple of people in the department that are doing that, and that has let them progress and provide their opinion on EEGs, which is something that's traditionally done by medical consultants. What do you think is the biggest misconception about careers in healthcare science? I think my immediate reaction to that is that people think that it might not be very patient facing, when in fact that is what we do all day. I think when you hear the word science, sometimes it leads you to think that you are in a laboratory or looking down a microscope. And that might put some people off if they're looking for patient-facing services and work. Healthcare science can be very, very patient-facing. I see, up to 9-10 patients a day, sometimes in clinic. It's really enjoyable, and no day is the same. Why is carpal tunnel syndrome so common? That's a really good question. It's partly due to possibly what we could call an anatomical flaw. So the median nerve travels through a tunnel, and that tunnel is made of the bones in our wrists and ligaments on the other side. And if the nerve wouldn't really become enlarged, but if the bones become enlarged, or if you're doing repetitive activities where you're flexing and extending your wrist with your work, then that can trigger the carpal tunnel syndrome. What do you think are the biggest challenges you have faced in this field, and would you say it is worth going for, and why? Possibly the biggest challenge that I have faced has been progressing and doing more complex studies. But this is, as you're studying now, doing A-levels or whatever study you're doing degrees, everything is always a stretch. And I think that is the case as you become a lifelong and adult learner. So as you progress and do more complex things, it should always feel difficult, and that's good because eventually it starts to feel more straightforward. And we have to have these challenges. It serves us well, keeps the brain ticking over. Would I say it is worth it? Yes, definitely. Healthcare science is a good profession, and it might not be neurophysiology, maybe you're not interested in brains, but cardiac science is really interesting, vascular science, audiology. We also have perfusion, which is, so these scientists are involved in looking at the heart-lung bypass equipment. There's such a wide range. I really hope that you go to the healthcareers.org.uk website and you can explore some of the different ones available. What kind of student do you think would thrive in this field? Somebody that likes patient contact, likes meeting somebody, but also perhaps a thirst to learn. If you want to keep learning and you want to do the best job that you can all the time, healthcare science is a great field. What advice would you give to students who are unsure whether medicine is the right path for them but still want a clinical career? I would say work experience might be key here. Try and get to see as much as you can. I know it's really difficult at the minute trying to get work experience in the health service. Try and get as much exposure as you can, read as much as you can, talk to members of staff, and try and get a feel for what you want to do. I would say try not to close any path at the moment. So what is the difference between medicine and healthcare science? How do the roles differ? So medicine, if we take medicine as being a career where you're training to be a doctor, when you train to be a doctor, all fields are open to you. You will become a doctor and you will work at consultant level in that field, but that can be anywhere. It could be in A&E, on a fracture ward, a GP service, in genetics, etc. Healthcare science is much more, it depends on which area you go to, and I definitely know more about the physiological sciences, but definitely much more to do with doing the tests and the science behind the tests. Possibly the doctors have higher level responsibilities, although I will say that is changing. Scientists are trying to develop roles and they are doing more and more. Skills or experiences would you recommend students start building now? Skills, definitely reading, getting up to date with your biology. You definitely always need biology for physiological science. Work experience again is really good, and just exposure and a broad understanding of what is involved in all of these different health careers. Do you feel there is good job security within health science compared to medicine? I would say that for my whole career, I haven't felt worried about job security, and I don't think on the whole doctors have. Whether that's going to change, because the world seems slightly crazy at the moment, whether that's going to change, I don't know. But I would have thought for both professions, medicine and healthcare science, job security is fairly secure. Whether AI is going to have an impact, I don't know, and finances and funding of the health service, I'm not sure. Do we need to do any entrance exams like the UCAT to get into healthcare sciences? Not as far as I'm aware. If you get to the stage where you want to apply to the scientist training programme, that is the MSc level qualification. There is like a logic test that you have to pass in order to apply. That's online and timed. That's the only test that I'm aware of. Usually they want to know to get into either the BSc or the MSc qualifications to date. They will ask you about your experience. So if you've had work experience, that will stand you in really good stead. And also your knowledge of conditions and your knowledge of what we will actually be doing in healthcare science.
All right, thank you very much, Jennifer.
You're
I
very
really
welcome.
appreciated that you came and gave a talk about this. I hope everyone really enjoyed it. I've just sent out the attendance form for all the audience to fill in to get the certificate. And after this meeting, I will send you, Jennifer, I'll send you an evaluation form to kind of talk about uh, how your experience basically.
Okay.
So yeah, I hope you really enjoyed it. And if you have any more questions, I'm sure we will stay behind for a little while to answer them.
Thanks, Serena.
Yeah, thank you.